Alright, so hello everyone. In this video, we are going to discuss about external cephalic version. In short, it's called ECV. Okay. Now, what is ECV? That means it is a manipulation of the fetus through the maternal abdomen to convert to the cephalic presentation. Alright, so cephalic version is intended to rotate the baby into a favorable condition called vertex presentation. Why? Because vertex presentation is the normal presentation, and it is a very it's comparatively very less risky to go for the vaginal delivery. Okay, so either you can manipulate the fetus from transverse position, or you can do it from the breech position. Okay, so this is how ECV is done. Now here is a very simple diagram. We need cephalic version, okay, for to have a normal vaginal delivery. But if it is in breech, then we manipulate by means of hands into the vertex position, and if it is a transverse position, we also convert into the vertex position. The question is it used nowadays? The answer is big yes. Yes, it is used. In the developed countries, it is used. Earlier, there was a study, there was a Cochrane review, and there was a meta-analysis, and there was increasing evidences that going for cesarean section for a breech delivery would reduce the perinatal mortality. Okay, which is true, but it is not true at that extent. So this time it's a high time to think about introducing ECV into the routine practice. Okay, so ECV is still useful, and it is practiced in the very developed countries around the world. Okay, now why we should use ECV more and more? Because first of all, it reduces the cesarean section rate. So many obstetricians, they think that a breech presentation at term is an indication for cesarean section, especially in primigravida. It's still, this concept is still very used, and many of the obstetrician wants to do this to reduce the risk to the baby. But again, cesarean section, we try to reduce the rate of cesarean section anyway. Okay, so that's why ECV is important here. ECV makes the baby's presentation to the vertex presentation, and that's why we don't need CS, and we can go for vaginal delivery. The second is, some of the patients doesn't want to go for cesarean sections. For some patient, let's say they already have a lot of cesarean sections before, or some of the ladies, in which we obviously will go for cesarean section again, but some of the ladies specifically want to go for vaginal delivery. They don't want cesarean section at all. In those cases, going for the vaginal breech delivery will be more risky. Okay, that's why we try to convert into a vertex presentation by means of ECV. Now let's take a statistics of the perinatal mortality. So in a developed country, a perinatal mortality usually is 1 per 1000 birth in case of normal vaginal delivery. So let's say if there are 1000 normal vaginal delivery with vertex presentation, the perinatal mortality is 1. Now with the cesarean section, the perinatal mortality is reduced to half, 0.5. But with the breech vaginal delivery, the perinatal mortality just goes double up, 2 per 1000. So you know my point. Going for breech vaginal delivery is obviously it's not very ideal. Okay, we should try to do ECV to convert into vaginal delivery. That makes the perinatal mortality half. So that's why ECV is important. Now, the question, the normal obstetrician, the students obstetrician who say that why not to go for cesarean if the perinatal mortality is 0.5? Why to go for, all these ECVs and then go for vaginal deliveries? Well, the question is CS is more dangerous for the mother in a long term in compared to any vaginal delivery, either a breech or vertex. So we have to think about the mother. Yeah, obviously baby is important, but mother is the priority by law, that you have to think about mother first. And cesarean section is dangerous in long term compared to the vaginal delivery. So as an obstetrician, always remember your primary duty is to save women, is to reduce problems with the women. And that's why you must try to reduce the cesarean sections, unnecessary cesarean sections. Okay, so that is the point where sometimes most of the obstetrician like and they just go for the cesarean one. Now, when we do the ECV in the primigravida, we do it from 36 weeks, and in the multipara or multigravida, we go for ECV from 37 weeks. Now, why? Because in primigravida, we think that around 36 weeks, the position of the fetus starts, getting stable. Okay, and in the multipara, the position of the fetus starts getting stable by 37 weeks, a little bit later than the prime one. That's why once we convert the baby from breech or transverse into a cephalic version by means of ECV, the new position, which is the vertex position, will stay for a long time because uterus makes the position stable. Otherwise, the babies, they like to roam either inside of the mother or outside of the mother. They like to roam. They just keep running and keep rotating themselves. But after 36 weeks in primigravida and after 37 weeks in multigravida, they tend to stabilize, making them ready for the delivery. Okay, now the most important thing here is success rate. What is a success rate? Well, overall success rate of ECV is 50%. In multigravida, it is even more, 60%. While primigravida, the success rate is 40%. So overall rate is 50%. So whenever you go and explain to a lady with a breech presentation and tell about the ECV, that okay, what is the success rate? That is 50%. Now, what are the complications of the ECV? Not much. Sometimes it is a fetal compromise because of the handling of the baby, handling of the umbilical cord. Abruption can happen, but it's again very, very rare. Preterm delivery can start and it can be very painful for mother as well. Now, what are the contraindications? That in this condition you must not do the CS. Well, there is no contraindication. Okay, you can do ECV virtually in every patient. But remember, what are you going to achieve? Let's say if the lady has more than 2 cesarean sections. So in those cases, anyway you are going for the cesarean section. You are not going to try the vaginal delivery. So ECV should not be done in these cases. Let's say sometimes the Rh negative mother is there and the baby is Rh positive. So ECV, it's basically a handling of the baby, so it can do the feto-maternal hemorrhage a little bit. So that's why sometimes you try to avoid the ECV with this kind of patient, but again it's not completely absolute contraindicated. Okay, any other obstetric reasons to avoid vaginal delivery are obviously the contraindication for ECV. Now, do we use any drugs? Yes, we do use drugs. Those are the drugs which relax the uterus. Okay, and the beta-agonists are used most commonly, salbutamol and terbutaline. Nifedipine is not used. Okay, in some of the literature they tried with the nifedipine, but again the latest study says nifedipine should not be used. Now, Where should the ECV be done? So you must do the ECV where the immediate cesarean section facilities are available, because sometimes any kind of problem, let's say any kind of problems can happen after ECV, and you might want to go for cesarean section immediately to save the baby. So yes, the facilities should be available, but it is very less likely that with the ECV the baby will be very compromised, so that you have to do a very emergency cesarean section. It's not going to happen, it's very rare, but anyway, you must have those facilities where you try to do the ECV. Now, where ECV should be done? You want to do in operation theater or you want to do in bathroom? Obviously you want to do in bathroom, because why? Because the severe complications are rare and you very rarely need theater quickly. Now it is painful, so you might use some of the pain reliefs. Most of the ladies are fine, but you can use some kind of regional anesthesia as well. So this is all about the ECV. We'll see you in the next video. Thank you very much.